Yes, sir. We are good to go.
Hello, and a very good evening to all the delegates and faculty members. I am Dr. Dhammadeep Dabade, and on behalf of Emcure Pharmaceuticals Limited, I welcome you all on the occasion of No Thrombosis Live Inbox. No Thrombosis Live Inbox is the scientific initiative by Emcure wherein we learn and understand about various cardiovascular interventions based on the live case presentations. It's my privilege and honor to welcome and introduce course director for this webinar, Dr. Shirish Hiremat sir. Sir is the director Cath Lab at Ruby Hall, Pune, been the president of CSI 2017, convener for National International Council of India, CSI 2004 to 6, proctored many interventional cardiologists and has given live courses across the globe. Sir participated in some groundbreaking trials. Welcome, sir. It's my privilege and honor to welcome and introduce course moderator for this webinar, Dr. Girish Nosundi, sir. Sir is the senior interventional cardiologist and director, Cath Lab, Apollo Hospital, Bangalore. Sir has extensive experience in the field of cardiology. Sir performed over 1700 angiograms through femoral, atrial, and approach. Sir has presented for several journals. Welcome, sir.
Thank you.
It's my privilege and honor to welcome and introduce our course moderator, Dr. Ankit Dedia, sir. Sir, the consultant interventional cardiologist at various hospitals across Mumbai, Holy Family, SL Raja, Global Hospital, also Bhartiya Arognidhi, Criticare Asia, KJ Somaya, and Life Care Hospital. Sir is the organizing committee member for National Cardiology Conferences by International Forum of Cardiology, Cardiology Summit 2015-18 and Cardiology Update 2015-17. Sir has authored various book chapters like Single Vessel CAD at National Cardiology Textbook 2018 of CSI and the chapter Heart Failure in Young and Elderly at National Medical Update 2017 of API. Welcome, sir. It's my privilege and honor to welcome and introduce speaker Dr. Ganesh Seth, sir. Sir is the consultant and interventional cardiologist at Department of Interventional Cardiology, Medanta Heart Institute, Lucknow. Sir will be presenting on coronary perforation. Welcome, sir.
Thank you.
It's my privilege and honor to welcome and introduce speaker Dr. Sri Harsha Guttukonda, sir. Sir is the chief consultant at Department of Vascular and Endovascular Surgery at Harsha Vascular Center, Vijayawada. And sir will be presenting on topic New Dimension on Management of Post-Operative Arterial Diseases in PVT. Agenda for today's webinar, opening remarks by the moderator, followed by first case presentation by Dr. Ganesh Seth, sir, and the case discussion by the moderators on the given case. Second case will be presented by Dr. Sri Harsha Guttukonda, sir, and there will be the case discussion followed by the case presentation between the moderators. We'll be having the concluding remarks by the moderators and note of thanks. With this, now I would like to hand it over to course moderator, Dr. Girish Nosundi, sir, for his opening remarks for this webinar. Over to Girish, sir. Thank you.
Dr. Deep, thank you. Emcure has been doing this wonderful human duty of discussing primarily the thrombosis. And you know, the major cause of death today is cardiovascular disease, and among them, the most common is the thrombosis. And we have not restrained or limited ourselves to just the coronaries. We're looking at coronaries, cerebral, peripheral. We're discussing all this on this platform, which has made this one of the most favorite meetings across the country. And today we have two wonderful, Dr. Gotikorna and Dr. Ashok, both of them presenting cases. And I expect to have a very lively conversations. Thank you. And I would request the first presenter to take on from here.
Over to Dr. Ganesh sir for your presentation.
Okay. Thank you. Thank you, everyone. Thank you, Emcure, and thank you, sir, for your kind introduction as well as proceedings. And I hope my slide is visible.
Yes,
Yes,
Dr.
okay.
Ganesh.
Thank you. So, going to my case. My case is a 64-year-old female who is presented with a chest pain on insertion for 3 months, and her angiography was done 3 years back and had a moderate disease in the LAD and RCA, and she was on medical management since then. But now, since last 3 months, her pain was aggravated. That is why he came to us, and her blood investigations were normal. 2D echo was done, which was also normal. Patient was taken to cath lab to look into the coronaries. This is the right scene where you can see there is no much occlusive thrombus or disease in the right system. And this is the left scene where you can see the left main is normal and proximal LAD as well as the proximal LCX is disease free. This is the cranial scene where you can see there is a 80 to 90% disease in the mid segment of the LAD. This is the disease in the mid segment of the LAD. So we first we have done balloon dilation of the disease segment, and then a 3x23 stent was placed in the LAD. This was the flow we obtained after placing this stent, but in the stent boost, we saw a slight depression in the middle segment of the stent, so we thought we should dilate it. And we dilated that. But after dilation, this is what we found. And the patient was slightly restless. And we saw a large perforation, which is grade 3 perforation in the stented segment, especially from the middle to lower side of the stent. So we took graft master, that is a covered stent in the stent to cover that leakage, and then after graft master, the perforation was sealed, and patient was looked. The echo was then reviewed, and there was a minimal effusion at the time of procedure at the table. And after 15 minutes, again a check angio was done, and which was there was no further leakage in the stent, and we successfully covered the whole of the perforation. So patient was promptly managed with a covered stent, and repeat scene after 15 minutes was done, and no leak was observed. At the time of procedure, only 2 to 3 mm of pericardial fluid rim was seen, and patient started having mild chest pain. But in the night, she developed hypotension with a mild breathlessness, with the tachycardia, and injection NORAD was started. 2D echo was reviewed again. Then the 22 mm anterior rim of the pericardial effusion was seen with the underfilled RV. Now the TLC was done, which was also increased to 24,000, and creatinine, which was also increased to 1.8, which was previously 1.02. So we took the patient to cath lab again. Check angio was done. There was no further leakage, but urgent pericardiocentesis was done at the table, and 200 ml hemorrhagic fluid was aspirated. Breathlessness gradually improved. NORAD stopped by afternoon, and patient gradually improved hemodynamically, chest pain improved, breathlessness improved. On the next day, 2D echo was done, and no further filling was observed in last 24 hours. And then surgical sheath was removed, and on the next day, she was planned for discharge. Although there was psychosis, then psychiatry opinion was done, and finally, patient was discharged successfully and without any pain and without any further expansion of the pericardial fluid rim in the echo. So this is just to tell the importance of the covered stent that should be available in the whole cath lab. There are two types of covered stents. One is the Craftmaster from the Abbott, and then second is the Papyrus from the Biotronic. Both have a different sizes and diameter. Craftmaster comes from 2.8 to 4.8 with the length of 16, 19, and 26. And then Papyrus come with the diameter of 2.5 to 5 with a length of 15, 20, and 26. And we as an interventional cardiologist should be familiar with the covered stent, because whenever this type of perforation, especially the grade 3 perforation occurs, it is actually life-threatening condition. If not tackled immediately, then it can lead to mortality. And the point which should be remembered, which should be in your mind while using the covered stent, is that the length of PTFE file in the stent is shorter than the strut length, and after the expansion of the stent, the PTFE file may be up to 1.6 mm from the each end of the stent graft. So the covered length can be 3.2 mm shorter than the whole stent length. So to summarize, coronary artery perforation is fortunately a rare but serious life-threatening complication of the PCI, which can lead to the cardiac tamponade, cardiac shock, myocardial infarction, or even death if there is no prompt intervention. And coronary perforation of ELS type 1, where only a crater is visible, and type 2, where there is a hematoma blush in the myocardium, can be managed conservatively with the serial echo monitoring, especially in the type 2. And if there is type 2, it can be managed with the prolonged balloon inflation also. And serial echocardiography obviously should be done to rule out any hemodynamic consequence of the pericardial effusion or any expanding effusion. Then covered stent, obviously they should be available in all of the cath labs. And there are two types of coverings, PTFE as well as polyurethane. And in Craftmaster, this is the PTFE covered, while Papyrus is a polyurethane covered, although there is no much difference in the outcome from both covering. The main disadvantage of these type of covered stent is that there is a high thrombogenicity and occlusion of covered branches if there is any branch passing through that the stented segment. So covered stents should be available in the all cath lab, and interventional cardiologists should be familiar with these stent systems. So thank you for your kind listening.
Thank you, Dr. Ganesh.
Thank you, sir.
It's a very, very common complication. It is not a very unusual complication that we come across. When you start discussing perforations, I think the most important thing is how to prevent perforations. It starts from there. And once you suspect a perforation, what are the things that you need? You need every day in a PCI lab, you need to have a small box which has these tools immediately available to you if required. Don't keep them somewhere far from where you are operating, especially a pericardiocentesis system and a covered stent. Every time you start looking at a probability of a perforation, you must tell the staff and keep, I hope you have it on shelf. You don't need it, but you need to check with them every day. I work in a busy lab. My technicians will tell me suddenly, sir, last night it was used and we don't have that size. So when you start it in the morning, you must make sure that what you call a bailout all of them are present for that morning. Not it was there yesterday, we should not assume that it will be there tomorrow, because something may have got used in the night if you're not the only operator. First. Second, perforation is a completely avoidable complication. It is an iatrogenic complication. It most often happens when we underestimate the expansile capacity of the vessel in terms of calcium, or a calcium nodule protruding, nodule, or we oversize the stent. Many a times it's not oversizing the stent, but it's oversizing the post-dilation balloon. And it is also more common in women in those areas where you said. So my request always is, although stent does not expand sufficiently at some point, you need to look at minimal luminal area. You need not make the entire stent cylindrical, because if there is a large plaque burden, imagine if somebody had a 90% stenosis, which is discrete, less than 15 millimeter, and when you put a 23 millimeter stent, the portion of the vessel where there is plaque, residual plaque, will not expand as much as where there is absolutely no plaque, because this plaque has to be accommodated within the vascular constitution, right? So if you try to make the stent straight, it is going to give away someplace. Second, I think when we choose a stent, we should choose it from intima to intima on an OCT or an IVUS, and when you post dilate, never exceed external luminal, means ELL. Okay, external elastic lamina you should never cause. When you choose the stent size, you use internal elastic lamina, but when you choose post dilation, you choose external elastic lamina. So having image on board when you think the stent optimization is not complete adds lot more clarity. Very rarely you may oversize and land up in perforation. Most of the time we undersize and leave behind malapposition or undersized stents. Very good discussion for bringing this on. The third, the minute you had a perforation, patient becomes uncomfortable. Such a free-flowing pericardial, I mean the perforation will definitely have hemodynamic significance, because it was like torrential flow that is happening. So you may not have been able to see, it could be more posterior at that point in time or a very lateral, because oftentimes we see in the epigastrium when we are doing the echocardiogram. So you must anticipate. Third, you must tell your cardiac ICU doctor and nurse that you have had a perforation and you expect this patient to have a hypotension. And if there is a hypotension, this patient needs volume correction, not inotropes. Oftentimes, they will call you that, sir, patient is having shock and not responding to 3 inotropes. Patient does not need inotropes. He is losing blood somewhere, and the chamber that gets compressed is the right ventricle. So you need to clearly tell them, please keep looking at the RV, look at the IVC if it is collapsing. You need to call me. I need to blindly stick a needle in pericardium and draw the fluid out. So these are the couple of things that you need to keep in mind. That I know if some cardiac intensivist starts inotrope on a patient who's had perforation, it's a disaster, because you will wait too late before start treating cardiogenic shock. So you should tell them, if there is a need for inotrope, call me. I need to make sure that there is no tamponade. And lastly, once I think you used a good size covered stent. 2 things I would like to tell you. Covered stent is not a normal stent. You just can't inflate it like a regular stent and hope to seal it. It takes a lot more time to expand and opposed to the wall. That means the native stent that you put, which is DS, which is perforated, and you put in a covered stent, the gap between the covered stent and native stent will still cause some amount of leak. So you need to go at least 18 or 20 atmosphere pressures for at least 15-20 seconds to seal entry and exit points of that. Otherwise, your covered stent may be malapposed to a large extent and the leak can continue. And as I said, the minute, as you clearly said, try and take the correct size. Never be very precise with a short covered stent. Many of the time you miss the perforation. So take a little larger. But unfortunate thing when this happens in LAD, because you lose a lot of septals and diagonals. So you can't take blindly a very long covered stent too, because you're going to leave behind a lot of residual ischemia. So these are the things to consider. If I were you, I would still, take a chance that I will occlude the LAD without a covered stent for a while, because it didn't look so nasty disease in the vessel. If occluding the balloon for a minute or three, if it seals, I may not put a covered stent in LAD because it's got many septals and many diagonals. But if it's an RCA,
At the site of stent, there is no diagonal. Although septals might not be visible, but there is not no big diagonal at that site.
Excellent. I think your judgment was you've been appropriate, but I'm just telling you, thinking loud. What if it was, proximal to mid across one large diagonal and large septal? In the hurry, in that anxiety of big perforation, the instinct is to put in a stent, covered stent. I think we can keep this as a backup strategy that let me just blow up a balloon, take a minute or three to see whether do I really need a covered stent. If it is needed, you should always put in. But then if I can avoid, why not? And largely, I think you need to put the patient now definitely for at least 12 months of dual antiplatelet and then take a call on it. Thanks for bringing this case. A lot of points for discussion. And I'll request my co-moderator for his comments on this. Dr. Ankit, if you could come on and comment on that.
Yeah, good evening, sir, and very good presentation, Dr. Ganesh. Congratulations for the result. Sir, as Dr. Girish has covered most of the things which we should do in a perf case. Just to ask you that what was the diameter of the post-dilatation balloon that you took?
3/12.
312, and your stent diameter was also
323. Yes, 323.
So that was important because technically, if you see, you have not upsized beyond the size of the stent. Now, sometimes possibility is there that there would be a calcium spicule, just given way, and this has caused such a large perf. And also would not want to know what was the diameter of the PK papyrus that you took.
I took that Graftmaster.
Graftmaster. What was the diameter of Graftmaster?
It was 2.8 by 19.
So Dr. Girish has pointed us a very important factor that your diameter of the stented segment was 3, and the diameter of the Graftmaster was 2.8. So till what pressures did you go to?
16.
So which is not very bad, which was good because Graftmaster nominal pressures would be more than 12. So you've gone up to 16. So assuming that the 16 atmospheric pressures would probably oppose up to a 3 millimeter stent. So despite you going up to 16 atmosphere, as Dr. Girish rightly said, that such covered stents have a lesser now in your case also 3 versus 2.8, the diameter was slightly on the lesser side. Going up to a more than nominal dilatation or pressures was important, and sometimes because of such situations there is some seepage of blood which has occurred in your case also, despite getting a good angiographic result. but there would be some seepage of blood which has passed through between the two struts, like the graft master and the stent. And
That
also,
is why presentation was quite late. In fact, I have completed the case in the evening, and I received a call that she's in hypertension in the night.
correct. So yes, that is one. Dr. Girish has covered beautifully all the points, and so there's nothing much to add. But yes, diameters of the graft master. Many a times, see now at our center at Holy Family at Bombay, we've got two graft masters. One is 2.5 and one is 3. But sometimes perfs occur at a diameter of 3.5. We had a recent perforation which happened at a 3.5 vessel, which was post-dilated to 3.75. Then we were in a big fix because we had only a 3 millimeter diameter stent, graft master. Then we went and we blew it to, we took a 319 and we dilated it up to 24 atmospheric pressures, which was again scary. So as sir rightly said, that your shelf of these instruments and your hardware has to be checked on a daily basis. That made us that the same stent was used by someone else a week back, and our technicians were not able to cover it up or get a replacement for that. So these are important points that Dr. Girish has wonderfully elicited. And as rightly said by him, that IV fluids at full strength, patient going on NORAD. So these are certain things. And what he said is right, that we should inform the cardiac ICU that we need to do an echo, interim echo. So you did the case in the evening and you got a call maybe 7 hours or 6 hours later. Am I wrong? I don't know. How many hours later did you take the patient?
5 hours later.
5 hours. So 5 hours is probably a bit too much. I would be more keen on getting a fresh echo done maybe at 1 or 2 hours post the
Echo
intervention.
monitoring was done every 2 hours.
Okay.
2 hours. There was a PDCC. There was a consultant who is looking after that echo.
Okay.
But I received a call after hypertension after 5 hours.
So yeah, but because the perforation was quite large, if you see the
Yes.
gush of blood, so possibility of this blood getting collected immediately before you put, and possibility after you put a graft master also is there. So, but good that the patient did very well, and congratulations once again to you.
Thank you, sir.
Thank you. Thank you. One last point I want to add. Just because we take a diameter of stent and we implant it, don't assume that it has become that size. If I take a 4 millimeter stent and implant it from left main to LAD, in LAD it does not become 4 millimeter unless I go at 12 atmosphere. Even if I go at 8 or 10 atmosphere, it'll still stay at 3.5 or 3.25. So oftentimes when we take a 3 millimeter stent and then you implant, and when you look at the proximal and distal edges of the stent being very well opposed or slightly oversized than the native vessel, and then you have a residual stenosis within the stent, then it's not appropriate to take a 3 millimeter NC balloon and go at a higher pressure, because probably vessel diameter is not 3 millimeter. In a healthy segment, the vessel looks already slightly overexpanded. So vessel size itself could be 2.75. This is just an intuition that you must develop, not chase just a cylindrical stent on a stent boost. But imagine, I think the more you will start imaging, you'll realize a stented area of more than 2.5 millimeter square is going to give you hardly any events in the distal, mid to distal LAD. And I'm sure here you had achieved more than 3.5 or 4 millimeter squares. So what I meant to say is, when you think, should I do or not, please consider the area that you could have achieved. And we have seen anything more than 80% area achieved. There are not too many clinical events, especially in mid to distal LAD. Thank you again.
Okay. Thank you.
Thank you, Dr. Ganesh. And we would like to go to the next case, please.
I request Dr. Harsha sir to go for your presentation and share your screen.
Yeah. Yeah, am I audible?
Yes,
Yeah,
perfectly.
very good evening to all of you. It's my privilege to be of this symposium. Myself to introduce, I am Dr. Harsha. I'm a vascular surgeon, located myself in Vijayawada in Andhra Pradesh. I am particularly mentioning this point because we are located almost about in the urban and the rural areas where we cover most of the villages around. So we deal lot of peripheral vascular diseases, and majority of the patients come at the end stage arterial diseases, where already there is established gangrenes or already infected wounds, already amputated wounds, and also patients have multiple comorbidities with the age span of 60 to 70 years. So majority of the age where the PVD is involved, and most of the people who are presenting to the hospital is about the geriatric age group, unfortunately. And so yes, compared to the statistics, along with the coronary vascular disease or the cerebrovascular disease, the lower extremity peripheral vascular disease also is coming to the high scale. And the amount or the risk of limb loss and the risk of complications immediately after the revascularization is also significantly increasing. So immediately after any endovascular or any open bypass procedures or any peripheral angioplasties or stentings, we are noticing significant patients who are coming back. At least 1 out of the 10 patients are coming back with rethrombosis, or again the patient developing hypercoagulability state, which is leading to the thrombosis, or instant failures or reduced ankle brachial index leading to the claudication pains. Because there are various factors reasoning for this. Maybe the patients are also not will be in the regular follow-ups, not on proper medications, and all these were the contributing factors. And coming to the clinical scenarios, what we see here, most of the patients with the 45 to 50 or 50 to 60 age groups who are already having diabetes, hypertensive, and also having associated coronary heart diseases. So almost 90%, 90 to 95% of the patients are also having associated coronary artery diseases or the previous history of MI or any cardiac events. So here I'm going to share a simple and normal case which we did recently in the last week. Most of the patients we have accelerated atherosclerosis involving the long segment. You can see the patient here. I hope my screen is visible, friends.
Yes, 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 Dr. Harsha. Go ahead.
Yeah, here you can see the 65-year male patient. He presented with gangrene grade 2 and infected ulcer adjacent to it extending to dorsum. The ankle brachial index was done, and the ankle brachial index of the index limb, that is the right lower limb, is showing 0.65. And we can see the diffuse narrowing of the superficial femoral artery at the adductor canal with chronic total occlusion of approximately 6 centimeters involving at the level of the knee joint. And distally, the flow is very less. You can see the monophasic flow in the Doppler and also in the ankle brachial index. And he's also having associated coronary artery disease. He's on antihypertensives. He's on antiplatelet medications prior to the procedure. So we have explained the patient attenders. We showed the risk. These are the typical presentations what we see here. Not only here, any patients here, they have abundant calcification along with atherosclerosis. Particularly in this case, it is little bit less what I'm presenting here, but we also have very much associated calcium deposition also. This is the one more case just to show it as a reference where you can see the calcifications and also area of diffuse calcification and also area of atherosclerotic diseases. I'll be just sharing the video of this one. This is the catheter is placed, and the multipurpose catheter is placed in situ. We did a diagnostic angiogram, and you can see the CTO lesion at the level of the adductor canal. This is the diffuse occlusion, and there is no flow beyond that lesion. And there is reformation noted at the tibioperoneal trunk. So just past the O35 guide where I used 5 into 100 balloon where we raised the pressure up to 15 mm mercury. And you can see the balloon is inflated. And little proximally also, I covered the diffuse lesion, where you can see the just dumbbell shape and the opening of the balloon here. So once the balloon was done, the diagnostic angiogram was repeated, and you can see the good flow noted up to the ankle region. This is just a comparison between the pre and post-operative pictures, where there is little bit of dissection and mild stenosis is noted. But again, as I told you, we also have a lot of financial constraints in these areas where majority don't have insurances, so no, we can't afford, the patients can't afford for majority of the stunting. So majority of the patients we do angioplasties and we'll keep them on regular follow-up, try to keep them and follow up. So eventually the patient developed good vascularity, the AB is raised to 0.9, and the good biphasic signals are noted in both DP and posterior tibial artery, and the wound started healing slowly. But the challenge for us is maintaining these patients because of the restenosis, that the rethrombosis rate is very high. What we are trying to do is initially we used to keep the patients on antiplatelet medications, later dual antiplatelet medications, keeping on heparin or enoxaparin during the hospital stay. So now in the peripheral vascular disease, the most these are the few what we have the important studies like Voyager peripheral artery disease trial, where it is compared 6,564 patients are taken greater than 50 years of age, and the patient has undergone lower extremity revascularizations compared to rivaroxaban, Novak 2.5 mg plus aspirin with placebo with the aspirin alone. So the bleeding tendencies are there with Novaks, but also compared to the major bleedings are not noticed. So in the cases of peripheral vascular disease, I significantly, with my personal experience, what I noted is the patient who underwent any kind of angioplasty, any kind of revascularization procedures with the balloon or with any stenting procedures, along with the antiplatelets in conjunction with rivaroxaban or any NOACs with or dual pathway therapies are giving significant outcome. And the restenosis rate and fatal bleeding rates are also very less. And we also noted significant maintenance of the wound healing, and also the patients are also on regular follow-up with this anticoagulations. And coming to the clinical implications, what I believe is patient with PAD are the higher also high risk of cardiovascular events in spite of use of available risk reduction therapies. And the strategies to reduce the risk are needed. So I think in the Voyager study, the vascular outcomes with acetyl acid along with rivaroxaban in endovascular or surgical limb has now demonstrated a robust benefit and net benefit for the combination of anticoagulants twice daily with aspirin in surgical patients also. So, my friends, I would like to just comment that the patient with critical limb ischemias and PVDs, along with the endovascular or any open procedures, we are making it as a practice to keep the patients on NOACs post-operatively and manage the patient for at least with 6 months of follow-up with these anticoagulant regimens. Thank you very much for giving us this opportunity.
Thank you, Dr. Harsha. May I just ask you one question? Now, in your practice, how do you use for an acute intervention procedure from the day of procedure? How do you give dual antiplatelets? Which medication, what doses? And when do you start DOAC, like, rivaroxaban 2.5 milligram twice daily?
Sir, generally what we do is generally we'll keep in the dual antiplatelets if the patient is having any hypercoagulability or the patient is having any thrombotic, acute and chronic presentations, like patient is having atherosclerotic disease and also thrombus also incorporated within the lumen.
Right.
Where we try to do a hybrid procedure, and initially we do at the time of post-operative, we have to keep on 75 mg clopidogrel and necosporin at the time of discharge. Now, at present, what we are doing is, if I'm doing any hybrid procedures, like the patient is, we are doing a thrombectomy and also like iliac angioplasty and followed by stent graft or any FEMPA bypass. Post-operatively,
right,
After the discharge, we are starting 2.5 mg BD and keeping it on follow-up for 6 months duration.
Okay, so it's a triple therapy for 6 months. That is.
No. If I'm giving Novax, I'm keeping only clopidogrel 75 mg.
Okay, that's fantastic. Okay, just to come back, I think you know, thrombosis and atherosclerosis, they go hand in hand, and we are realizing, in spite of potent dual antiplatelets, whether the aspirin, beyond clopidogrel, now we are using ticagrelor and prasugrel. In
Yes.
spite of dual antiplatelet, very potent, there is still residual ischemic events that are happening. Means there are more thrombosis, more ischemia, restenosis, all are happening.
Yes.
To reduce these ischemic events, you need to look at what we call net clinical benefit. Every time you increase the antiplatelet or anticoagulation action, it comes at the cost of increased bleeding. If you want to reduce ischemia, some amount of bleeding would increase. But if that increase in the bleeding is not very dangerous, not requiring hospitalization, no intracerebral hemorrhages, no abdominal GI bleeds, then you are safer in using them. Second, you have to not only focus on high ischemic burden patients, you also need to categorize every patient into what is the bleeding risk, HBR, what we call high bleeding risk patient population is significantly increasing. These are people who have anemia, who are elders, frail, who had a previous GI bleed, uh, who require an anticoagulation. There are multiple patients that will not tolerate very high intensity antiplatelet or coagulation therapy. But in most others, where they do not belong to HBR category, we as cardiologists give for the first 1 month, first 1 month to 12 months, varying duration. We give dual antiplatelets, and at the end of that, if somebody has diabetes, chronic kidney disease, heart failure, peripheral vascular disease, we prefer to use 2.5 milligram rivaroxaban along with an aspirin rather than dual antiplatelets beyond that period, because this dual pathway inhibition has shown to reduce future cardiovascular events. And those patients who have severe peripheral vascular disease and also coronary vascular disease, these are very, very ischemic patients. Their chance of having another ischemic event is very high. So the benefit also that accrue by addition of another anticoagulation could be more. But you should be judicious to first calculate bleeding risk and then initiate these people. Second, the duration of DOACs is still not yet known. It seems like an indefinite choice that you'll be making unless they fall into high-risk group. So we'll start on them on one antiplatelet and 2.5 milligram twice rivaroxaban. How long, we do not know. I think this is my understanding. And thanks for bringing this conversation. Again, this is also very, very important discussion that just putting everybody on two antiplatelets may not solve problem of quite a number of patients where you may need a DOAC. Dr. Ankit, I would request you to make your expert comments on that.
Yeah, so good case, Dr. Shri. And I also feel the same that yes, rivaroxaban 2.5 milligram in peripheral vascular diseases and complex cardiac cases is an important way to tackle and prevent further MACE events. And that's why 2.5 milligram BID, as sir rightly said, is important, and it's a good dose, and it definitely will help in your patient. So congratulations for your case, and it was an intriguing case to see such a fantastic result after your intervention. Thank you.
Yeah, thank you, sir. Sir, just for the point of discussion, So generally after the open surgeries, generally what we do is as a vascular surgeon, we do a FEMPOP bypass, we do PTFE grafting most of the times, which is almost 35 to 40 centimeters length. So initially what we noticed is we used to keep them on enoxaparin or heparin during the hospital stay, followed by dual antiplatelets.
Hmm.
Now, in this scenario, can we compare the same studies, whatever are there for the angioplasties, to the open procedures, and we can extend the anticoagulation doses to 1 year or 6 months? Because this is unpredictable for us during the practice. What we are noticing is very high rethrombosis rate who are having this associated coronary artery diseases.
So in such situations, yes, see, there is no data available for such situations where FEMPOP bypass, post FEMPOP bypass, whether I don't know, Damdeep is, I don't know. I have not come across any data for peripheral vascular disease, operative peripheral vascular disease, followed up with NOAC like that. But I think it's a good idea or good thought, but it has to be backed up with you should not have bleeding tendencies in such patients, because these patients do rivaroxaban 2.5 does have lesser bleeding tendency as compared to the higher doses. But yes, it would be a good option where you can give an ecosprin along with a rivaroxaban 2.5 milligram BID in your post FEMPOP bypass patients if the stent thrombosis or thrombus burden is high in the post-op phase. So it would be a good, so NOAC would be a preferred drug as compared to a clopidogrel, but I don't know how much data we have backed up with such a scenario. What do you think,
Yes.
Girish?
I think very well said. Uh, we have not reached the perfection of cocktails for antithrombosis, whether it is antiplatelets or anticoagulation. And there are so many trials where they're trying many drugs at different strengths, starting at different timelines from the acute event. It is an ongoing science, and whichever has certain reliable data, I think we should accept it and practice it. I think that's where rivaroxaban 2.5 milligram twice daily has been conclusive so far. But if you have another thought process like yourself, Dr. Harsha, I think you should try 100 cases and publish what happens.
Sure, sir.
So because you have those volumes, so you're treating so many of them. So please publish 100 cases. That may help. But the problem, what happens is, in the best interest of the patients, many a time you may do what you think is right, but if it becomes a medical legal case, will you have sufficient safety for yourself? That becomes important. So when you want to do something different, my request to you, take a written consent that this is not the standard protocol, but you would like to treat this way, and this could be the complications, and I agree to it. That's for your own safety.
Yeah. Sure, sir.
Yeah, I think, thank you. Being a vascular surgeon and an interventionalist, we were doing all the procedures quite some time back, and you guys have come and relieved us of this. And in the past, they were all coronary hardwares, but now you have your own wonderful hardwares. But still, we crisscross these days into each other because of little expertise that we have in our own domain, which becomes useful to the other person. And managing thrombosis is also very, very common to us. Probably you do not have sufficient data in the peripheral vascular arena as compared to cardiovascular arena. I
True,
think you
sir.
can borrow from us, but if you think there is, you would need a different strategy, please gather some data and share, and we'll be really grateful. Thank you.
Sure, sir. Privileged. Thank you, sir.
Uh, Dr. Ankit, any other comments?
No, sir. I also agree that if you have good volumes, Dr. Shri, you can, as sir rightly said, probably with a good medical legal backup, you can get your own data published, and maybe it turns into a guideline.
Yeah. At least, it becomes an expert consensus if we start collecting proper data. And we have so many patients in this country. We just need to have that scientific temperament and, as he says, consents. Consents are very, very important these days. Thank you. Thank you, Team Emcure. I think we have had a great meeting. Are there any questions in the chat box that need to be answered?
There are few of the questions, but they are not too much clear. Dr. Naseem is trying to ask something about the loading dose. I think that's for the first case. Probably is asking for loading dose, antiplatelets, maybe Tika.
Okay, if I can briefly tell, the loading dose for an aspirin could be anywhere between 75 to 325 milligram. Loading dose of clopidogrel, if it is not an emergent procedure, then 300 milligram. If it's an emergency intervention required, then 600 milligram is the loading dose. For a prasugrel, it is 60 milligram loading dose followed by 10 milligram once daily. For ticagrelor, it is 90 milligram, 2 tablets, 180 milligram loading dose followed by 90 milligram 2 times daily. If you're using ticagrelor, then don't use an aspirin not exceeding 100 milligrams. So you always use 75 milligrams, because if the aspirin dose is more, it decreases the potency of ticagrelor. These are the loading doses we use. If you're giving rivaroxaban for a peripheral vascular disease or coronary artery disease, 2.5 milligram twice daily is the dose. No loading dose required. You just start with 2.5 milligrams, stay twice daily. Any other question, Dr. Deep?
No, Dr. Anil Agrawal tried to ask something, but again, his question is unclear, so I couldn't.
Can you read out?
No, sir. He just actually tried to share something, but probably
Okay.
so he was not able to put the question rightly. So I think so that's
No
like
problem.
towards the conclusion of this hourly webinar, and I'm really thankful to see the insightful discussion around this webinar. I'm much thankful our speaker, Dr. Ganesh Seth sir, for nicely and interestingly presenting his first case on coronary perforation, followed by the moderation and the discussion around that. I'm much thankful on behalf of Emcure to Dr. Shri Harsha sir for again wonderfully presenting his case of the PVD with the interventions what he just shown to us. And both the moderators, Dr. Gillis sir, as always, you are with us for all the webinars throughout this series of the webinars in each month. And I also thank Dr. Ankit Dedia sir for sharing your valuable time and contributing to the discussion throughout this webinar. With that note and with the promise to come up with once again the next webinar with some more interesting cases, I just want to say good time ahead and a good night to all the delegates and faculty members. Thank you.
Thank you.
Thank
Thank you.
you.
Thank you.
Thank you. Good night. Good night, sir.
Everyone. Bye.
Bye.